Hi, my name is Stephanie Martin, and today I will be going over chronic medication management for patients with ascites. Before I get started, I would like to say that the information presented is based on the listed references as of the date of this presentation. Ascites is the pathological accumulation of fluid in the peritoneal cavity. The peritoneal is the tissue that lines the abdomen wall and covers most of the organs in the abdomen. This can further be broken down into three different severity classes. So grade 1 is mild and detectable only by ultrasound. Grade 2 is moderate and has moderate symmetrical distension of the abdomen. And finally, grade 3 is large, causing marked abdominal distension. So the graph here on the left shows the fluid accumulation in the abdomen. It takes 1.5 liters present to be detectable by physical examination. Otherwise, the ultrasounds will be needed to further classify the severity of ascites a patient has. Here are some of the main causes of ascites. The most common is cirrhosis. About 60% of patients that have cirrhosis will have ascites occur within 10 years of being diagnosed. Some other causes are increased resistance to portal blood flow, hypoalbuminemia, sodium intake exceeding excretion. And then the diagram on the right-hand side there shows the impact that cirrhosis has on the body and the different effects that lead finally to the cause of ascites. So cirrhosis will lead to portal hypertension and then arterial vasodilation, which will reduce the effectiveness of arterial volume. This will then activate our vasoconstrictor systems, most importantly, the renin-angiotensin system, which further will lead to the production of aldosterone. And I will touch more on that in a little bit. This will then lead to persistent activation, leading to retention of sodium and therefore leading to ascites in our patients. So now that we looked at a few of the causes for ascites, we'll look into the treatment options that are currently available. The first line treatment is currently spironolactone, and this is largely because of the hyperaldosteronism that we see in patients with ascites. Spironolactone works by competing with the aldosterone for receptor sites in the distal renal tubules, increasing sodium chloride and water excretion while conserving potassium and hydrogen ions. It also is believed to block the effect of aldosterone on arterial smooth muscle. So as I stated previously, patients that have cirrhosis, their renin-angiotensin system gets activated, which you can see here on the diagram, which then leads to the production of aldosterone. So spironolactone will work by blocking, competing for the receptors that aldosterone has an impact on, and then therefore blocking all of the effects that it has on these organ systems. The most important ones for us are the kidneys and the heart. So when we give a patient spironolactone, it'll block the effect that aldosterone has, therefore leading to sodium and water excretion and potassium and albumin retention. And then in the heart side of things, it will lead to vasodilation, which will be important to help lower the portal hypertension. So the initial dose that patients are started on is 100 milligrams per day. This is then titrated up every 3 to 5 days based on response intolerability. And then this up to 400 milligrams per day can be increased. The major side effects that we have with spironolactone are hyperkalemia and gynecomastia. This medication can take days to weeks to be effective, so it will not provide the patient with immediate relief, which is why we often turn to furosemide, which I'll be discussing next. But while we're still talking about this class of medications, it's important to bring up eplerenone, which is in the same class as spironolactone. However, there's only been one study looking at this medication used in ascites. And while it had comparable effects to spironolactone and actually could reverse the penile gynecomastia that some patients experienced, medication is not currently recommended as first line because of lack of studies evaluating it in patients with ascites. So as I mentioned earlier, the next treatment option available is furosemide. This medication works by inhibiting the reabsorption of sodium in the ascending loop of Henle. Effects with this medication are typically seen within 1 day, so it's much more favorable for the patients because they have an immediate response to the medication. Like spironolactone, it will be titrated every 2 to 3 days up to a max dose of 160 milligrams per day. Other loop diuretics are not currently being used because they did not exhibit superiority in the studies and they cost more. Furosemide and spironolactone can be used together to have a combined benefit for the patient to help excrete more fluid for them. This is typically only done if spironolactone was not having a full effect for the patient. So here on the left-hand side, I have a picture of the kidney. So furosemide is a loop diuretic and works at number 3 here on your screen. So it works in the ascending loop of Henle, and then the aldosterone antagonists work in the renal distal tubules and collecting ducts. So loop diuretics will increase sodium, potassium, and chloride excretion, and then spironolactone will work to excrete more sodium, which then leads to more of a diuretic effect, and then it preserves the potassium. So when these medications are used together, they have a stronger diuretic effect for our patients, therefore providing them more relief short and long term. So this was just a quick overview of ascites and why it occurs and how we are currently treating it. Thank you so much for taking the time to watch.